Morning, everybody, and welcome to the 2024 Greening Healthcare Annual Forum. As you know, this is our big strategic event of the year. This is when we reflect on and provide information on where are we at, how are we progressing with respect to greenhouse gas emissions related to hospitals, and we do our serious planning about 2025 and beyond, because this is a really interesting time as we head towards 2030. There's some serious targets in terms of emissions reductions for Canada and globally, and we'll share with you today how North American hospitals are progressing in terms of living up to where those targets are. Are we on track or not? We'll share that information. Final shout out before we move on to Ellis Don. Thank you for a healthy breakfast. That was greatly enjoyed. And you'll see Ellis Don again on this group. Greening Healthcare is a member organization of Climate Challenge Network, which is a large nonprofit that runs these kinds of programs in different sectors. And you'll see our industry partners on the slide at the bottom there. And please take a note to note. You'll see their names cropping up in other places. Some are exhibitors today. Some have sponsored parts of the day. And it's fair to say, without our industry partners, we would not be able to do what we're doing with Greening Healthcare. But it's beyond financial support. We treasure them as our guidance, our kind of North Star. We talk to them on a regular basis about where things are at, what their advice is. They're so connected with the marketplace, with all of you. They're tremendous technical and strategic support for us as well. So credit to our industry partners. Thank you for the work that you do and for making everything possible. We begin all Climate Challenge Network events with a land acknowledgement, and that speaks to the ancestral and unceded territory. We share this territory with the Indigenous peoples of Canada, the Inuit, the Métis, the First Nations people, who, again, we share these spaces with them. We're in the traditional homes of several nations in the Toronto area, but the Huron-Wendat, the Haudenosaunee, the Anishinaabe, and the Mississaugas of the Credit River. And many of you will know Toronto and York region governed by Treaty 13 with the Mississaugas of the Credit River. I think the last sentence of this is the one I relate to most. We really hope that the work we're doing to try to take some progress in terms of healing the natural environment, that will be a meaningful contribution to our collective responsibility as stewards of the environment. That's what we are, that's why we're here, and we have work to do on that front. And we run through the morning agenda. We've got we're into the welcome and introductions right now. We look forward to Dr. Rao and the keynote in a moment. This is the first time that we've had a clinician giving us our keynote address, speaking to us from that side of the fence. Again, with climate change, with the climate crisis, with climate action, we're very much all in this together, and getting the perspective from the clinician side and how we can work together on these things. I'm greatly looking forward to that conversation. Then I'm going to take some time to frame the issue. What's happening with climate change? Where do hospitals fit? Why are you at the front line? Why is there so much to be done? Are we making any progress? And my colleague, Gillian Henderson, who's been doing research with a number of you on what gets in the way. What are the barriers? What are the challenges? What are the things that hospitals are having to deal with as they also try to tackle a meaningful contribution towards climate action? What are those issues? So she'll summarize some of that, which really sets the stage for the day, which is we've got a lot of work to do. It's not going to be easy, but in our view, we have no choice. We have to get on with this. After that break, we have the executive panel. So by then, we'll have context from where is the world going with respect to hospital emissions. We'll have context in terms of what you've told us about what the challenges are that you're facing. And we have an exceptional executive panel to then dig into those things. And as always, it's kind of an armchair format. The The panelists will be up here. I'll be asking questions. They'll be asking each other questions. What's profoundly important is that you ask questions. So we love to keep my colleagues within greening healthcare moving around. We've got microphones here and we'll bring them around the room. But please think about your questions, because our hope today, but when you leave today, that you're really in a position to start doing things differently tomorrow and planning for 2025, which is not so very far away. We then in the afternoon wanted to talk about specifics. So we know we have a challenge, we know we have an opportunity, we know we have a responsibility, but there are two areas that greening healthcare has been focusing on. One is, how do you decarbonize existing hospitals? And once again, we've got an exceptional panel here with different approaches, different experiences, but really positive results. And we truly want this to be a positive session, not doom and gloom. We don't want everybody going home this evening feeling suicidal about everything, even though there's lots to worry about. There's lots of good things happening there we can build upon, we can replicate. And the key is that we translate those into specifics that each of us can do as we move forward. So the decarbonizing existing hospitals, my colleague Amandeep will be leading that with that panel. And then we get to the other side of the equation, which is we're building 100 new hospitals across North America every year. And we'll share statistics, data with you to show we're not doing that great a job of it in terms of energy efficiency and in terms of greenhouse gas emissions. The majority of new hospitals we're building today are failing to come close to the kind of targets we have to meet on a go-forward basis. They're not coming close to what the National Energy Code in Canada speaks to today. So we had, how many of you were at the Cortellucci Vaughan, the summer workshop earlier this year? Great. So we're going to summarize and build upon that. And again, we've got an exceptional panel of hospitals, constructors, designers, to dig into what we learned at that session and carry it a bit forward in terms of what do we do differently going forward. So every time we spend 200 million, $500 million, $1 billion on a new hospital, it turns out to be as energy efficient, as environmentally efficient as we know how to do it. So that's the second part of it. That's the second panel within there. I want to prep you for the idea of rolling up your sleeves, because traditionally our workshops and these forums, we do a lot of telling. We give you information. We tell you what you could be doing. We tell you what others are doing. And this year, we really want to try harder to do some asking. So please make sure that you stay right to the end and rolling up your sleeves. Again, my colleague, Gillian Henderson, our vice president, will be working through the idea of Slido. We're going to ask you all at different tables to talk to each other and come back with consensus ideas that we're going to record and put up on the screen about what you think you need on a go-forward basis to play your part, so that your hospital can play its fair share of emissions reductions, and we'll show you what that fair share looks like, how big is that number, and so that every industry player in this room, and there's a lot of you here, have a good way of connecting with hospitals and saying, we can help. How can we help? How can we move forward? Let's talk to each other. Let's go there. Because this very much is a team sport. We can't get to emissions reduction targets individually. We need to work together. A lot of today is going to be about collaboration. We have, as last year, a cocktail reception at the end of the day, because everybody's heads by then will be full of ideas, full of new approaches. Please, if you can, stay around for half an hour. And once again, network with each other, talk to each other. What have you learned? What have you shared? And in particular, feedback to us. This is what we need. What do you need from greening healthcare? What can we do to help you move forward? Because we absolutely, positively need to move forward. Mention Slido. You can play with this right now. Grab your phone and kind of get on there with a QR code or with the link that you have there, because that's your portal to us for this afternoon. typing in your ideas, your thoughts. Slido, if you haven't seen it before, does an amazing job of sorting and organizing things and making words that everybody's saying bigger and making words that, that nobody's talking about smaller. But this will be our roadmap for 2025 as we finalize our program for 2025 for greening healthcare, as we talk to our industry partners, as we talk to our utility friends. This is where our information is going to come from. So please stay and please be part of that conversation. So, welcome and introductions. We're kind of almost halfway through that already. First introduction is to greening healthcare. If you're not familiar with us, we'll come back to it at the end as to what it looks like, but it's our 20th anniversary. We started this back in 2004. A number of the hospitals in this room were among the first group there and have stayed with us ever since. The program is 10 times as big as it was back in those days. But happy birthday. This time we had cookies in the summer. We don't have a, I don't think we have a birthday cake, do we? Oh, we got more cookies. Okay, so have a lucky cookie with greening healthcare and help us celebrate our 20th anniversary. But it seems like the work is only just beginning, so we got a long way yet to go. And want you to take the time to meet our exhibitors. There's a reason these folks are here. This is not a big healthcare gathering where there's everything from beds to furniture. This is very specific and targeted at energy efficiency and emissions reductions. And the folks who have taken the time to support the event and gather around, this is your chance to talk to a group of organizations that are targeted towards this and can really help. And to remind myself, they've got the products you need. So they got kind of the leading edge products that are going to be part of your decarbonization efforts on a go forward basis. We got Armstrong, I think, are in that area. Optimizing hydronics is a big deal. If you can't balance effectively your hydronic systems, you aren't going to be able to put in the electrification, the decarbonization equipment that you'll need in the future. Belimo in a very similar, and again, I can't quite see around where everybody is, but you'll find them. There they are. So Belimo, energy valves. We're doing some research with them on hospital applications to figure out just how good a job they can do of helping to manage hydronic systems. Corel over there, adiabatic humidification. Those of you in hospitals, you know, steam is the one big the one big steam user that we've been struggling with has been humidification. How do we get to adiabatic evaporative humidification? The products are over there for you to check out. HTS and Kilmer, we talk with them on a weekly basis on new configurations of products, enthalpy wheels and humidifiers, and how do we put these things together? Those two organizations for us, they're the imagination. They kind of see the future. They attract the products and they figure out with us how you can combine them together. We've got the contract. So there's a lot of equipment in this room that you will be using over the next 5 years. Take the time to get connected with it now. We have our contractors. We have Blackstone and Ecosystem that take on these big deep reduction projects and help you with all of it. The planning, the installation, the actual performance coming out. So these kind of contractors are essential. We're so happy we got both of them in the room. Go chat with them, hear about the projects, and you'll hear more about those projects as the day goes through. We have our friends from PCL, who as big contractors are thinking through what are the new delivery models that are going to be necessary to get to decarbonization in all kinds of buildings, not just hospitals. Chat with them about the forward thinking. And again, you'll hear from Mark Henderson over the course of the day. And Thermogenics, you know, our first industry member, Thermogenics is here with us again. The challenge we've given to each other is how can we get every hospital boiler plant in North America as efficient as it can be? You know, we know decarbonization, we're going to use less boilers, we're going to use less natural gas in future, but that ain't going to happen for a while. Meanwhile, thermogenics is absolutely committed. We're going to take every one of them, and many of you in this room are already working with them to tune up, to optimize the boiler plants you have in place right now. And we've got our consultant friends from Smith & Anderson responsible for some of the most energy efficient hospitals that we found. We spent a lot of time with Kurt and his colleagues talking about how did you do that? What do we do differently? And again, the panels today are going to be talking about how do consultants, contractors, and equipment suppliers and hospitals work together more effectively to come up with the kind of outcomes we need within the timelines, which are pretty short. We are running out of time to get this stuff done. So meet our exhibitors. We brought the right people together in the right place here. Take the time during every break to go chat with every one of them and make sure you pick up on what can they do for you, and you've got those contacts on a go-forward basis. Let me talk about what we'd like to accomplish today. We always start off when we're planning these events, we start off with writing down this year, because this year is not quite like last year, which is not quite like the year before. This whole agenda is moving really quickly. But we really want to build this case that, like, our language these days is around urgency, opportunity, and responsibility. We'll talk at the end of the day about Dr. Penny Ballam's advice to us last year, the chair of Vancouver Coastal Health, that we are running out of time. Like, we see it every week. In fact, every day on the news, there's something about the climate, people who died in Spain, people who died in Florida, and it's getting worse. So there's an urgency around this. There's an urgency to act. There's an opportunity. We can save a lot of money. I think, David, what you said at Cordelucci Vaughan, what are we going to tell our kids and our grandkids about what we did? Because we were here in our places we're in at this time. What are we going to tell them about what did you do during the climate crisis, Mummy or Daddy? What will we say? We have an opportunity here, and it's a big one. It's an important one. And we do have a responsibility. This is the healthcare sector. You're at the front line of the damage that's being done. We'll talk a bit more about that by climate change, as well as the opportunity to make a real impact on cutting greenhouse gas emissions. So we want to build that case so that by the time you leave here at the end of today, you have very clearly in your mind, I got to do something about this, and I can do something about this, that you're ready to go. We want to raise awareness of your numbers. Every hospital in this room, and I think there are 70 people in this room representing hospitals, and some of you, many hospitals. Every hospital has a number. We're going to show you where those numbers are found, and we can provide them to you. You have the potential to reduce greenhouse gas emissions by running what you've already got, your existing infrastructure, more efficiently. You have a number. You should leave here. I remember Alan Kelly. Are you here, Alan? I know he's registered, but Alan at Markham Stouffville Hospital, it was $1.1 million a year. As he walked around his hospital, he had in mind 1.1 million, 1.1, where the hell is it? You know, I go, you should have that number in mind, and everybody you work with on your team and your contractor should have that number in mind. What percentage reduction? Is it gas or electric? We can share with you that number. You need to understand that number, because then you know what your fair share is we're going through. And the rest of it, we need to hear from you. So I said that to begin with, I'll say it again right now. We need your collective feedback on what your priorities are, what you need, and we will do everything we can to make it happen. Like Greening Healthcare is asking you, here's what has to happen within the hospital sector. You tell us what you need to make it happen, and we will do everything we can to make that work for you. We want to give you specific takeaways. If you don't leave here today with, tomorrow I'm going to do this and this, then we failed. And that's where you have the chance. Pick up the microphone, ask Michael to come over and say your piece about, I don't get it yet. Like, I've got this situation, I got these challenges. What am I supposed to do about that? So we want you to have specific takeaways, and what came out of our discussions with with the panelists before we began here is that none of us can do this together. We surely can't. Like, I don't know enough to figure out how to fix this conundrum of making all North American and hospitals around the world more efficient, but together we actually do. So who do we need to talk to? Who do we need to bring together? What kind of collaborations can greening healthcare help put together so that the right people are talking to each other about the right things, taking the right action, and seeing the results? So thank you for kind of bearing with me as we try to set the stage for the day. I mentioned earlier, I am just thrilled to have Dr. Rao to give that side of the story that we've never really heard clearly before. And that's perhaps the biggest collaboration when we get clinical staff working with facilities folks and energy folks. Good things are happening. To introduce Dr. Rao, David Angelo from Creative Energy is here, a newcomer to the greening healthcare family. And David, please take that away.
Thank you, Ian. First of all, it's an honor to be here with all of you who are fighting the good fight. So thank you for all the work you're doing. The Canadian Medical Association reports that almost 5% of national emissions are sourced to our health system. The negative impacts on human health by climate change are becoming an increasing risk and burden to our financially challenged healthcare networks. At Creative Energy, we design, build, own, and operate net zero decarbonization pathways for and with our healthcare partners. As a 66-year-old firm, our low carbon district energy systems reduce the use of fossil fuels while avoiding significant capital expenditures and ensuring long-term operational cost predictability. It is a pleasure to introduce today's keynote speaker, Dr. Anita Rao, who is not only very humble, but is very driven to see that our medical centers becomes leaders in sustainability. Dr. Rao is an anesthesiologist at Trillium Health Partners in Mississauga, where she also serves as a physician lead on the organization's environmentally sustainable team and has been practicing clinical medicine for over 30 years. In addition to being the chair of Ontario's anesthesiologist environmentally sustainability working group, it's a mouthful, Dr. Rao is also the co-chair of the Cascades Sustainable Perioperative Care Pan-Canadian Network. Additionally, Dr. Rao chairs the Toronto Academic Health Science Network's Sustainable Operating Rooms Working Group and is actively involved with the Canadian Coalition of Green Healthcare on the national campaign focused on mitigating nitrous oxide emissions within health systems. Without further ado, please join me in welcoming Dr. Anita Rao to our podium.
Okay. Thank you very much for the kind introduction, and it's a real pleasure to be speaking with you today. So I'll be speaking about health systems decarbonization, really about collaboration between everyone in the infrastructure professionals and facilities and how we can work together with clinicians. So I acknowledge that I am an uninvited settler who was born in the traditional territories of the Mi'kmaq. I currently reside, live, and play in the traditional territories of the Haudenosaunee, the Huron-Wendat, the Anishinaabeg, and the Mississaugas of the Credit. Additionally, I acknowledge that I have not always treated the land, air, and water with the sacred reverence which it deserves, and I commit to learning from our Indigenous knowledge keepers about how to live in harmony with the planet. So I have some general objectives. We usually do these for clinical talks, but really what I want to speak about is how we can all collaborate to urgently decarbonize and to really pick the low-hanging fruit together and to get rid of some really easy emissions. To give some context about where Canada is on the global scale, and I know a lot of you know all of this already, but just to set the background, The bottom slide is our national greenhouse gas emissions. This is 2022 data, so very recent. And it takes all of national emissions, just divides it by population. So simple per capita greenhouse gas emissions. It's not really personal emissions, includes industry. We are number 2 in the world next to Saudi Arabia, which of course runs on a fossil fuel industry. So we have to do something urgently to maintain our global responsibilities. Often I get asked, well, we're in a cold country and we're in a large country. Well, the States is a large country too, and the top graph is the emissions over since industrial times, and they consistently have lower per capita greenhouse gas emissions. Sweden is one, they're a cold country too. So that's just our national emissions per capita. What about healthcare? Are we any different than we are with just our emissions overall? And the answer, unfortunately, is no. We are with the same group who is always the highest emitters in the world, and that's Australia and the States. We emit more than 1 ton of CO2 per capita for the delivery of health. The circle graph, I guess it's on your right, is a representation of healthcare emissions in the world. We are 0.5% of the population globally, and we emit 2% of the world's healthcare emissions. So clearly we are an outlier. But perhaps this is because we have really great healthcare. We have very good healthcare in Canada. So is this why we use more resources and we keep people healthier? Well, the answer, unfortunately, is no. Now, there's many healthcare metrics to assess the quality of a health system. I'm just using a very simple one here, healthcare emissions versus life expectancy. And so we have on the x-axis, we have tons of CO2, and on the right axis, we just have life expectancy, and these are healthcare emissions, I should specify. So Canada is on the wrong side of the graph. Lower life expectancy than many of the EU countries, particularly Japan, Singapore, and we have a lot of emissions. So we're using a lot of stuff, but we're not getting our outcomes. We're not as healthy as we should be. The States, of course, is an outlier, and that may be worse after tomorrow. So Canada's health system really lags behind other countries, and we're not getting the quality we should get from all the resources we use, because after all, healthcare emissions are just resources. It's healthcare delivery and the equipment we use. So I just want to introduce the concept of low value care. And a lot of you work in the hospital, so you understand this and have been familiar with this. It does come from the clinical side, but I think we can extrapolate this really to infrastructure and to facilities. So low value care is defined as services that are medically unnecessary, and provide no benefit to patients. So Choosing Wisely Canada estimates, and Choosing Wisely is the big global push and organization to really improve the quality of healthcare around the world. And that 30% of our costs in healthcare is completely unnecessary and unuseful. And in some cases, this causes harm. When you provide more tests for patients, you find things that are irrelevant, you expose them to more tests. So if we extend this concept to any process in the health system, we can see that we're doing stuff that we shouldn't be doing. And if we get rid of low value care and low value processes, first of all, no patient will be affected and you don't incur any costs. So this is a pictorial representation. I was very lucky to be working with a group that had this incredible artist, which created this low-hanging fruit of health systems decarbonization. And so the ripeness of the fruit is so if it's a peach tree, so if it's more yellow, it's more GHG reduction. If it's bigger, it's sort of your higher ROI. And everything on the bottom, all the low-hanging fruit, are actually about reducing what you don't need. So deprescribing, choosing wisely. And the two examples that I want to give here will be what we can collaborate, clinicians and facilities experts, is nitrous mitigation and HVAC setbacks. These are very low on the tree, meaning they don't really, you get a very high ROI, or in the case of nitrous mitigation, none, no capital investment, and you have a very big bang for your buck in terms of carbon GHG reduction. I'm just going to give a little background about our Environmental Sustainability Committee, because this is how we did it at our hospital through the committee. I've been working on sort of decarbonization for several years and sort of running around my hospital, knocking on the wrong doors, making enemies. And some people in the room here know that. And so in 2022, our leadership decided we really need to formalize this process, and especially because it's becoming more important. In Mississauga, we have one of the leanest healthcare systems among OECD countries as far as beds per patients. We cannot increase our capacity. And so one of the things that increases the need for health systems is actually increased local pollutants. So we set a terms of reference in 2022, and we have broad representation. So of course we have facilities which was already participating with their energy conservation and management and demand management plan. And we have clinical groups, we have food services, extremely important, MDRD, and patient support services. And my co-lead is from patient support services, and I think that's really important to have that broad perspective. And so we have our sort of our mandate below. So we do have board approved metrics and targets for 24-25, and I just show those to you briefly to say that our committee is accountable. We have executive sponsorship for our committee. So it's not just a green team. We actually do provide protected time for our staff. So one of the big projects that we're participating now is nitrous mitigation. And this is something that every hospital in Canada should participate in. There's two aspects to nitrous mitigation. One is decommissioning current systems, and one is making sure that these systems are not installed into new builds. To give some context clinically, nitrous oxide, the same thing that's released in agriculture, is laughing gas. It is an anesthetic. It's been around for 150 years. It's actually fairly obsolete. And it is the third most important greenhouse gas in the atmosphere. It has a very long half-life. So it was originally used as an anesthetic way back shortly after ether was introduced. And it is currently has very low clinical usage in North America. Now, it is only used by 3 groups in a hospital, and or 3 stakeholders, I should say. Facilities in many hospitals manages nitrous oxide. Sometimes it's pharmacy. Obstetrical analgesia is occasionally provided by nitrous oxide in North America. In urban centers where there's anesthesia services, it's often an epidural, but definitely plays a very important role in obstetrical analgesia. The third group, which is often the most difficult to convince, are my colleagues. And that's why a lot of anesthesiologists are involved in nitrous mitigation. So it's really only 3 stakeholders. And so it's not that difficult to manage nitrous. So is nitrous an issue? So medical nitrous is 1% of all nitrous oxide that is in the atmosphere today. It is the 3rd most important greenhouse gas. This is healthcare emissions, and this is around the world. And the big blue, I don't know if you can see that actually, but the big blue is CO2. The orange is methane, so natural gas that's used for the energy for the hospitals. Shockingly, that blue is nitrous oxide. So that does represent a significant portion of your total greenhouse gas emissions. And it's estimated that 0.05% of the greenhouse gas emissions in the atmosphere is medical nitrous. 100% unnecessary, and I'll explain why. So centralized nitrous systems, and I think all modern hospitals, so everyone here probably has a centralized nitrous system in their hospital. These have been found about 6 years ago by a very perceptive pharmacist from the UK named Alifia Shakira, and I say her name because she often isn't given the credit she deserves. And she noticed that procurement of nitrous does not match what the clinical use is. We all have EMRs now. We can actually dice down with Slicer, Dicer, Epic, with various other programs to see how much we're using. So it was being lost, and there was always some concern because nitrous is a street drug. So is it being siphoned off? And it turns out that they found these central distribution systems leak tremendously. They leak at lots of different places. And that bottom picture is from the Cascadia Group, which is Providence Healthcare in the Northwest States, which has really gotten rid of their centralized distribution system. So these are current systems now. So there's lots of places, and all of you know much more about these manifolds and these joints. And there's even an OR outlet where this is leaking from. So in the UK, when they discover this, they've actually decommissioning all their nitrous systems. They use a lot more nitrous than we do in North America because just culturally they use it for obstetrics. You don't need to use centralized distribution systems for nitrous. It's actually very efficiently delivered by point of care in the labor suite. And in fact, up until 2021 at my hospital, we delivered at point of care, and then we actually connected it to the centralized system. So people are very used to delivering it that way, perfectly efficient. Patients will not notice a difference. It does not provide any extra work for labor and delivery nurses. So the UK is getting rid of these centralized systems. So what about in Canada? What are our audits like? Well, there's several audits that have been done. Unfortunately, for the Quebec audits, we didn't get this up on the slide when we presented to the CSA, but they had 26 audits of hospitals. And this was actually brought to the Quebec Ministry of Health. And the entire Ministry of Health is looking into maybe what can be done about this. All hospitals leaked on the order of 90 to 99%. So that means for every 1 liter of nitrous that's delivered to a patient, 99 has leaked out of the system. Very environmentally inefficient as well as costly. So this is me and one of our facility experts, Roy. He took me down to the centralized distribution system at Credit Valley. We have 144 K-tanks in our 3 hospital sites, and this translates to 1,250 tons of CO2. We don't use it. It's an obsolete drug. So it's very low use. It's older. There are some, actually I shouldn't say that. There's a few people who were interested in continuing to use, but we don't really use it. So all of this leaks out. It alarms when the tanks get down to 20%. It's taken back to LIND. LIND has to discharge the last 20% by CSA guidelines, fill it up, and comes back. We have an orthopedic site where we don't give any very few general anesthetics. It's not used at all. And that orthopedic site has no obstetrics. So I went down to the nitrous room. We have 10 K-tanks just sitting there and leaking 9.5 tons of CO2. So we just turned it off, and in 1 year, 1 person noticed. And that was one of my colleagues who actually came from a different hospital. All he said was, "Oh, I didn't know we had nitrous, not an issue." So that's how we did it locally in our systems. And there are many other hospitals that have done it. And my colleague, Dr. Stefan Williams at CHOM always says they have a beautiful brand new hospital that many of you know about and just built. 2 years later, they decommissioned the nitrous system. So please, please, please do not install these systems into the 100 new hospitals that are being built. We are working with a few anesthesiologists and healthcare engineers with Canadian Coalition of Green Healthcare. We got a funding from ECCC, from the Implementation Readiness Fund, and to have a Nix the Nitrous campaign. We are calling it Nix the Nitrous Pod of Protoxide Azote. And we're asking for 2 things: decommission your current system and don't install the system. The biggest barrier you're going to have if you are in facilities and infrastructure is actually getting anesthesiologists on board. Do not take on that battle yourself. We will do it for you because we have a whole campaign. We have a campaign within Ontario, and now we have the Canadian Coalition campaign. We will go and provide all the medical evidence to their anesthesia department, and we will make sure that it is decommissioned or it is not installed. So collaboration at a systems level. So many hospitals have done this in Canada, but we looked at the CSA guidelines, and the medical gas guidelines are actually being revised currently. So we actually presented to the CSA, and this was the simplest thing we've ever done. We have a 1-hour meeting with them, and they were all on board. And of course, many of the healthcare engineers already knew this. And so they just needed sort of our blessing that this is, you're not stepping on professional practice. This is within the scope of care. Additionally, Canadian Anesthesia Society guidelines, American Societies of Anesthesiologists, and importantly, the World Federation of Societies of Anesthesiologists have said to us, the main stakeholder of this drug, please don't use it anymore. So we have the professional backing, so we just need sort of the infrastructure support. And at CSA, they were very supportive. So we're just waiting. We presented at the end of April. We're waiting to see what the wording is, but we hope that it will be strong wording, really, instead of saying, consider putting in these areas, instead of that, to say, consider not installing it all. I'm just going to talk quickly about HVAC setbacks, because this is another area where we can have collaboration between facilities, professionals, and clinicians. And you all know what HVAC setbacks are. It's just decreasing your air exchanges during non-operating times. But many hospitals don't apply them, despite CSA guidance to do so. And I think this is an area where we can really collaborate. And again, this all comes down to low value care. There's nothing happening in that room when patients are in there. Why are we continuing to use up all this energy? So at THP, it actually took quite a while to get approvals for HVAC setbacks. And this is something where I think we can actually leverage all the expertise from the various stakeholders. And one of the stakeholders that had some doubts about decreasing the air exchanges when patients weren't there was actually IPAC. And of course, IPAC's mandate is to make sure that there's no infections. So they were very concerned about surgical site infections, but we have lots of data from Europe and the US. We presented that data, and it took about a year before we actually got approvals from IPAC to do so. And so then our facilities conducted testing. We started with a pilot because IPAC did want some reassurance that we wouldn't be doing having some unintended consequences like increased surgical site infections. So we have a standalone brachytherapy suite, which is in the bottom of our hospital. It's not connected to any ORs. And there's no emergency surgery. So we actually could put the HVAC setbacks on a schedule. So we got approval to do that in April 2023 after some upgrades. And the annual cost savings are $6,500 per year. But the CO2 savings are 7.2 per year. So that's tons of CO2 per year. So that's significant. That's one. We have 40 ORs. So we have this orthopedic center that I mentioned before. We also have no emergency surgeries at this hospital at all. So really easy to get HVAC setbacks. So our facilities team did a bunch of upgrades. And again, we went to IPAC and they had no issue whatsoever because of the pilot we performed. The clinical teams, I actually thought that that would be a barrier because it's an orthopedic center and they're very concerned about surgical site infections. I don't know if anyone read my email, but certainly no one cared. So they were not a barrier. And sometimes I'm right, sometimes I'm wrong. I can't predict. So these are our energy savings and our natural gas savings, which of course is really important, and a return on investment, including the incentives, is 8 months. I know the HVAC guidelines for the CSA are actually being released, I think, next week. Very soon, but sort of during my research of this, I noticed that the CSA guidelines are very, very conservative compared to the ASHRA guidelines and some of the EU guidelines that we saw. And one of the things where I think we can really collaborate and work with is the CSA guidelines for air exchanges in our recovery rooms are actually the same as the OR. It's really no different than sitting in a room like this in the recovery room. And particularly the day surgery, the second stage of recovery, the CSA guidelines say if nitrous oxide is going to be exhaled by the patient, then we have to increase the air exchanges. First of all, we should not be using nitrous oxide, so hopefully we get rid of that. But secondly, the reason people like nitrous oxide and why some clinicians don't want to get rid of it is because it actually is eliminated from the patient within 2 minutes. So 3 hours after that patient is in day surgery, there is no reason to have increased air exchanges because of this theoretical consideration that we're going to have nitrous oxide around the rooms. So maybe that's something clinicians and people in this room can work on if the new CSA guidelines don't reflect this. I'm hoping they do. So this is our sustainability committee. This is our sort of emissions reductions and our cost savings. So, you know, we really focused first on trying not to ask for money because that's harder. You kind of have to prove yourself before you ask for money. So everything here is cost savings except one thing, and that's sort of the institution of reusable gowns. That's kind of clinical. And so reducing low value care and reducing unnecessary emissions saves cost, right? Reduction saves cost, and that's 30% of what we can do. So the big win for us is our center will not have a centralized distribution system for nitrous. So how do we scale and spread? So that's great that everyone in their individual hospital is producing these initiatives and getting good results, but that's really not enough. So in the NHS, they have the Getting to Net Zero, and I'm sure all of you know this document. And so they do have a nationalized health system, so it's a little bit easier. We have a somewhat fragmented health system, and of course it's provincial. So how can we participate in really getting some of these interventions that all of you are doing as well? How can we spread those? So some provinces like Nova Scotia and Newfoundland and BC has local health authorities. Alberta, I'm not sure if they still have their health authority, but that was a way to leverage, and that's unfortunate anyway, but that's a way to sort of leverage scale. But in Ontario, we don't. We do have Ontario Health, but that's not really their mandate. So there is some fragmentation here. So my group at Ontario's anesthesiologists, one of our sort of deliverables is banning desflurane, which is this very impactful anesthetic drug. Before we got rid of it at my hospital, it was 826 tons of CO2 per year that we were emitting. We've decreased that by tenfold to 80 by getting rid of this one anesthetic drug. Anesthetic gases, I know I seem to be very focused on this. I am an anesthesiologist, but the reason is anesthetic drugs are 5% of the carbon footprint of an acute care center. So it's not trivial. When you think of energy is 14%, anesthetic gases are 5%, and all of it is unnecessary. So the UK has gotten rid of desflurane, and actually the EU has proposed this, and I think it's passed as of 2026. So we were actually trying to work with the Ministry of Health to ban it. We weren't getting that much engagement. So I'm just going to give an example of grassroots scaling and spreading, which is very energy intensive, like because we have to do a lot of education. So that's my very good friend and colleague, Dr. Peter Manikevs. He runs something called the Chiefs Campaign, where he will go into any anesthesia department in Ontario and provide rounds on greening the OR. And this is a whole suite of energy efficiency, as well as reduction and removing plastics in our environment, which is not only an issue for an environment, it is an issue for human health. So we decided, okay, we're not getting anywhere with the top down, the Ministry of Health. Let's send an email out to every hospital in Ontario, and that's what we did. So when we started this 2 years ago, Halloween 2022, 4 hospitals had taken desflurane off of their formulary. Now we have 28 within 2 years. I don't know if you can see all those names. That's just how PowerPoint came out, but there's some heavy hitters in there. So really big hospitals. All of NOSM does not have desflurane. That means no resident from NOSM is training with us. All of Kingston, Queens, and Toronto Tasman is 12 out of 13. If you're interested to know who didn't get rid of it, I can tell you privately. In clinical talks, I say it publicly, but maybe that's not appropriate to shame here. So through that, we and through Dr. Fiona Miller's Collaborative Center of Climate Health and Sustainability, an OR scorecard was developed. There's a nationalized scorecard, but it was first developed for the Toronto Academic Health Sciences Network. Again, there were 2 hospitals in 2022 when the scorecard was developed. Now 12 out of 13 have gotten rid of desflurane, and we do have nitrous on that too. So it's a key deliverable for TASN. This scorecard is reported to your CEOs. If you are, and I don't want to be too Toronto focused, but it is reported to the CEOs, and that has really driven change. So that's sort of the grassroots. This is just a perioperative care playbook. I just show this because if you want step-by-step, or if your clinicians want step-by-step instructions on how to do something on that scorecard, we have a playbook. So just to sort of end, because that was kind of clinical, but I think people in this room really have the agency to affect top-down change. And so a couple of really interesting collaborations that have really come out recently is with Accreditation Canada and with HSO, which of course advises Accreditation Canada on what to look for. So Accreditation Canada came out with just their leadership and governance standards for environmental sustainability in 2023. This is huge. So now if this is an Accreditation Canada, we assume that all hospitals will have to get an environmental committee, will have to show some results. So we were accredited shortly after these standards came out, and we recognize there's a real opportunity to help engage with Accreditation Canada to get those more robust. So they didn't really have a checklist at that time, and it was just starting. So I think everyone here can actually advise Accreditation Canada on how to improve and to see what they're looking for. There's no like ROPs, required organizational processes yet. And so this is in its infancy, and we can all work with HSO to help advise. So to that end, Cascade, which is the big ECCC greening organization that Dr. Fiona Miller leads, that's pan-Canadian, is actually developing case studies currently to present to Accreditation Canada. It's a very small working group. It's 5 of us. There's nobody from facilities. So if someone wants to write a case study, it can go to HSO. It will be co-branded with Cascades and HSO, and that can affect Accreditation Canada. So just a call out for anyone who's interested. Other organizations, we're a small group of people. Ontario's anesthesiologists, only 1,500 people we represent. We haven't had much engagement from Ministry of Health. Our big ask is actually to have an Office of Environmental Sustainability within the Ministry of Health. We've been lobbying for this for years. Other health authorities, because they have health authorities, like in the Vancouver Health Authority regions, in Nova Scotia, Newfoundland, and in Alberta, had an Office of Sustainability within their health authority. I don't know what will happen now, but so opportunities there. The CSA, of course, many of you advise for CSA and with CHESS and with, I just put the OHA there. I know it's this national forum, but that is our best way in Ontario to sort of get scale and spread. So to summarize, we're really behind in Canada with decarbonization. Our peer EU countries are much further ahead than us. We have a responsibility, and I think people in Canada think that we're green. We're really one of the worst in the world. That's not to be discouraging, but that's really as an opportunity and to really show that we have to maintain our responsibilities to the global community. I just want to stress a lot of things I know in infrastructure and facilities cost money. The low hanging fruit is reduce low value care. Just get rid of the stuff that we don't need. And your clinicians are your partners. We can tell you what you don't need. Excuse me, don't worry about treading on professional practice. We can speak to that. There's many clinicians who are now getting more interested. And so many standard organizations are really eager to collaborate. And, you know, one of the things I always tell people is we're always talking amongst ourselves. We're in this room because we're the ones who are interested in this. You have to talk to the people who aren't interested and make them interested. So thank you very much for this wonderful opportunity.
Stay there, Anita. We
Okay.
haven't done
Sure.
with you yet. Questions from anybody? Yes, Matt.
So that's a great question. So it's very local. It's actually really interesting, and it's actually interesting where you trained. So it depends. So we sort of like there's a lot of, we have over 35 people in our environmental group. So we have people from all different types of facilities, healthcare systems. So we actually target the change management depending on what they want. So there's particular subspecialties of anesthesia for nitrous, which are the obstetrical and the pediatrics that sometimes are resistant to this. We can still give them nitrous. We just give, I didn't want to get into the technical details, but we can give it at point of care. You can actually give it on their anesthesia machine. We are making the choice at my hospital not to allow that because it would require a retrofit of our machines, which would be about $50,000, and it's not best practice to use it. The Canadian Pediatrics Anesthesia Society, the subspecialty, we have somebody trying to work with them, but they're not there yet. So at Sick Kids, you know, maybe we can just deliver it on their machines instead of this incredibly inefficient centralized system that where everyone gets what they want, but you're not wasting the money. But we can talk later about what your facility, what your system is, and I can advise you on whether you should just get rid of it completely or if maybe something will have to be done.
Yeah, and wait for the microphone, please, because this is being live streamed, by the way. So.
I'm actually the vice chair for the CSA MedGas, and so I've participated in this presentation. So we are more than willing to go from should consider to thou shalt. The issue we have, and we can talk later, is we're not really clinicians. We regularly access them, but the group in of itself, the technical subcommittee, doesn't have clinicians. So what we're struggling with, and then this is where we can talk later, is if there was a national equivalent of the people that you represent that would issue a document that says from a clinical perspective, there's no need to use this, I can guarantee you'll see in the next version, will say thou shalt not use. But in the absence of that kind of national document representing anesthesiologists or whatever the appropriate group is, it's very difficult for us to, I'm addressing you're looking forward to the language you're going to use. It's predicated on the clinical support that we can call upon.
So we do have it, and I think anyway, I can send them all to you. So Canadian Anesthesiologist Society has do not use. American Societies of Anesthesiologists do not use, World Federation. And actually the Canadian Anesthesia Society is coming out next week or the week after with an environmental statement that says don't use. So definitely it's an all best practice guidelines. That is new. They are 2023 guidelines, but that is what our society has said. Those are guidelines, so people still use it, but that is best practice. And so we have those, and I will send them to you after for sure.
We have time for one more question. Maybe two.
Hi there, Lisa Van Lint from University Health Network. I just want to say thank you very much because I think that was a wonderful presentation about all of these abilities that we have for that low-hanging fruit. One of the things that you mentioned is the importance of getting out of this room and making sure that we have these conversations with everyone else. I really think that that's so important. We had that experience with talking to our anesthesia department about desflurane a few years ago, and it was amazing how receptive everyone was. And also, I just want to make a point about the importance of procurement, because one of the things that they did right away is stop buying it and changing their contracts. And that's really hard to do, but you need to be able to do that thing. So it's not so much a question as realizing and trying to highlight some of the things that you've said in your presentation, which is absolutely wonderful. Thank you.
We got data coming back from across North America that gives us a real sense of where we're at and what more we need to do. So this idea, and my friend Corey at the back here, this was his creation. Greenhouse gas emissions are probably the one area of pollution that we don't jump up and fix immediately. If a few red bags drop off the back of a trailer, you're going to clean that up immediately because it's visible, it's there, you're hearing back on it. If you have a leak in the basement, I just remember with sick kids back in the day, when you're up to your ankles in water, you fix it. Greenhouse gas emissions, much bigger problem, but it's not visible enough. And sometimes it feels like we're sleepwalking into the climate crisis. It gets worse and worse and worse. And we say, oh my Lord, it just got worse. But it's not visible enough that we get into it. And we have to take ownership of the individual responsibility here. The government has great intentions. If you recall, Dr. Penny Ballum at this event last year, again, chair of Vancouver Coastal Health, former deputy minister of health in BC, very serious person, saying government can't fix this. So when we see climate change, when we see the climate crisis, and we're inclined to say the government ought to do something, the government can't do anything. They don't have the tools, they don't have the levers. All they've got is taxes and giving us our money back to do the right things, and they got codes and standards. That's kind of it. The things that need to be done have to be done at the local level, and that is only you that can do that. So they can provide incentives. We'll hear later from Mike Rohan from Northwell Health in New York about local law 97 and carbon caps and all kinds of things. There are carrots, there are sticks, but at the end of the day, it's our individual responsibility. Good intentions in Toronto. Don't worry too much about the overlays there, but this slide you've seen before. The blue line is Canada's commitment with respect to buildings, which is a 41% reduction in emissions from 2019 by 2030. The red dotted line is Enbridge Gas's gas supply plan, and they're going in the opposite direction. So we're almost halfway through that period of commitment there, and we've got worse, not better. We absolutely, from the macro picture level, we're not going in the right direction. What we overlaid on there previously, you see, is we've got the IESO here, we've got Enbridge Gas here, they have their DSM plans, they have their CDM plans, their programs, they're there to help. So a lot of things are happening in here, but it's absolutely down to us to take individual action. But that's what Ontario's committed to. This is what Canada's committed to. There's a very constant theme here. You see, the yellow piece in the middle there is buildings, but they're all supposed to be going down. And the evidence we're collecting from real data from hundreds of real hospitals says that, in fact, we're either flat or creeping up. And I'll show you some more of that in a moment. So this you're going to see more of from greening healthcare over time. We mine the data. So this is just Ontario hospitals. And this we call a tornado diagram for obvious visual reasons. Every horizontal line here is a hospital that's reporting under the broader public sector mandatory Ministry of Energy annual reporting. So every horizontal line is a hospital, which means your hospitals are in there somewhere. The green ones at the top there are showing savings. And how encouraging is that? You can see the median of all the ones that are making savings. But in terms of electricity use, the numbers there show us that for all the hospitals that are making headway, there's almost as many that are going backwards, and this is just electricity consumption. My wording today, again, we're talking about specific takeaways. If you don't know where you are on that chart, you need to. And we're happy to share it with you. Just give Michael a call. We've got the data on every one of these hospitals. You have to know where you stand, and you have to be brave enough to share that with your hospital, with your executive. And there's kind of no excuses, as they say. Whatever the reasons are for the red ones at the bottom, which are going up, the planet doesn't care. If we're going in the wrong direction, we're going in the wrong direction, and we have to fix it or at least mitigate it in the short term and make sure it's fixed. So this is the big idea of greening healthcare reporting. It'll be tornado diagrams every year. We'll issue these things on a fairly regular basis, and it's our scorecard. But the end result here, as you see, is on electricity, we're making small progress. Of greater concern, this is natural gas. Here we got more hospitals going up than going down. And some of those have legitimate reasons. They may be, Sinai Health downtown, that's kind of, everything's been torn apart. But the majority of these hospitals are not aware that their energy use is going up. It's complicated, it's weather, there's a lot of things going on. They're not aware of it. It's operational missteps, it's equipment deterioration, it's failure to identify and get the maintenance department to fix the things that went wrong. It's failure on the service contractor side. We've seen more than one occasion where the service contractor comes in, switch things to manual so they can do their work and doesn't switch it back to. It's all foolishness, and it all comes back to we need data, and we need reporting, and we need organizational responsiveness, and we'll come back to that in just a moment. So overall in Ontario, between 2019 and 2023, we're going backwards, and that we should be concerned about. Of course, COVID's in the middle of that. We've looked at many of these hospitals. COVID is almost a non-issue in terms of what's driving these results. And if we went back 5 previous years, you'd see exactly the same thing. So this becomes total energy. When it's red, that means overall we're going backwards. And this is kind of another way of showing the same thing. These are the buckets. The hospitals in the middle are within plus or minus 5%. So a significant number of hospitals, nothing changed. But the ones on the left went up, the ones on the right went down. If you don't know which of those buckets you're in, you need to, because we absolutely positively have to start taking action. Does this kind of make sense so far? This is Ontario. But we know how to do this. If you've been to CHES events recently, my colleague Amandeep on a couple of occasions has presented this information where Alberta Health Services says, I want to take a group of our hospitals and take hold of this thing, and did HVAC testing, did controls adjustments, looked at required air change rates according to CSA and made sure that they were properly balanced. What this shows on a monthly basis is savings across all of those Alberta Health Services hospitals. And look how good the numbers are. And they didn't spend a lot of money. They just did the hard work to make sure things were running the way they were supposed to, and set them up appropriately using HVAC testing contractors, using their building automation system contractors, and running through. So this was the electricity results. This is what happened on gas. If we looked based on the previous chart at all of the Ontario hospitals, there'd be as much red on here. When you get hold of a significant group of hospitals here and you manage them carefully and you keep your eye on what's happening and you get the reporting back, you just get the odd little glitch there. You see that little pink one on the bottom there? They had a setback, they were on it, they fixed it. So this can be done, we know how to do it. And today we're going to be exploring, so why aren't we doing it? If a whole group of hospitals can get these kind of results collectively and keep them there over an extended period of time, we know how to do this. We've got to get this right. This was the recommissioning project, and I see my friend Vicky kind of smiling. The ISO has its recommissioning project. I know Mike Rohan, they're looking at recommissioning for all of their hospitals in New York. And again, this is intended today to be an empowering session, not a woe is me session. We're done for, we're doomed. I love this every year. We get our awards every year, the hospitals that despite the odds, despite all the challenges that you're facing, they faced them too. They worked their way through it and they got the results. And they generally had a whole team working together on this stuff. So this was our awards presentation from the Cortellucci Vaughan meeting earlier this year. These folks know how to do it. Many of them are in this room. Many of them you're going to hear from over the course of the day. Take the time to chat with them. Again, honestly, this is not that complicated, but it's a lot of work. It's a lot of work. So running through that. So Similar story in New York. New York's got all kinds of regulations. I'm sure we'll hear from Mike over the course of the day about what's happening in New York. So Local Law 97, there's mandatory audits, there's mandatory reporting. New York City really is a leader in terms of putting the policy framework in place, and New York State is right there with them. Like wonderful aspirations, wonderful good intentions, but we run through, and it's a similar kind of story. Again, the Greens all made the savings. So on the electricity side, that's great news, but on the thermal side, again, we got as many of their hospitals going up as we've got going down. And at least in this case, the net total, Mike, where are you, Mike? There you are. You're doing better than Ontario is. You're net positive. But these net positives are tiny. And you can imagine if we could just get all the greens and fix the reds and not let the reds happen, you can see how much bigger these numbers would be. We're going to argue the case that we can, looking at the data from hundreds of hospitals, we can cut greenhouse gas emissions due to hospital operations by more than 30% by 2030. So if you run it through, that's about 5% a year. So for us, bogey is 5% a year. That's what greening healthcare is adopting. We're not seeing that right now. We're not seeing that even with greening healthcare members. Again, they go up, they go down. We got to deal with the increases, and we've got to build upon and reinforce the savings. So the same thing, here are the buckets. Mike, I'm not sure how many of your hospitals are in each one of these buckets, but over the next few weeks, we're going to figure it out together. And that's where we go from there, because we can learn from the greens and we can heal the reds. Looking at California, I believe live streaming is a colleague from Kaiser Permanente, and we got Adventist down there. So a lot of hospitals, the same thing. California is very progressive in terms of regulatory policy initiatives. But once again, and everyone is different, right? And you can picture these stories, the stories behind these stories, right? This is just data. It's publicly reported data. It's readily available. We just process it and run it into a spreadsheet. But here, and we don't really understand why, thermal energy, actually, natural gas is doing really well. And for whatever reason, electricity is creeping up. And it was the opposite previously. They had a lot of fuel cells. They had a lot of, the desert is paved now with photovoltaics. But for whatever reason, over this 4-year period, electricity crept up, gas went down. We learn from this. We study this. We identify the best practices, the success stories. We share it with everybody. That's what we do with these things. But the key is kind of running through this here again. Here are all the buckets, and we're really interested in the buckets. But just staying with that for a moment. Overall, it's 2 steps forward, sometimes 2 steps forward, 2 steps back, 2 steps forward, 3 steps back, 2 steps forward, 1 step back. We just got to have 3 steps forward, no steps back. And as we talked at the beginning, our goals for today is every hospital will leave here with the commitment that you're going to be on the green bars there, and that you're going to get to the high levels of performance, because it can be done, it has been done, it has to be done. Let's talk about your fair share. We touched upon that a little earlier. And again, forgive the repetition, we're into these ski slopes. And every building type we look at has the same ski slopes. Let me just... check for time. Once again, this is an international chart, by the way. We've got hospitals from the UK, from across North America as part of this group. Again, every horizontal line, these are standard benchmarks, right? Every horizontal line is a hospital. Your hospitals are likely on this chart, and if they're not, they're easily added. The blue is electricity use per square foot. The orange is thermal energy, typically natural gas, but sometimes oil, sometimes steam. And you can see where the damage is done. It's on the thermal side. Like the blue is reasonably consistent. You know, you can manage electricity use in hospitals. No jurisdiction we found yet knows how to manage natural gas and scale up that management, except a few of the hospitals in here. So we got local success stories. We don't have systemic change. It's the thermal energy we have to focus on. Nobody understands that a leaking steam valve can double. One leaking steam valve can double the gas consumption of a hospital. It's beyond people's comprehension. The idea that you can change set points on enthalpy wheels. My colleague Amandeep and his panel will look at this. You can change the set point and take the heat recovery from 10% on that system to 90%. This idea of just how much impact, how much leverage these simple changes are, again, is generally beyond people's comprehension, and setting up the procedures, the reporting procedures, the management practices to make them happen on a consistent basis is the key to success. So when you hear from Rob Simpson from Ontario Shores today, that's his key to success. He's on top of it. His whole team is on top of it. And they're the biggest saver of every hospital within greening healthcare over the last 5 years. Your fair share is to get to the top quartile of this chart. When we give you numbers, when we give greening healthcare numbers, it's getting everybody to the top quartile. And again, this is an international picture. If we do that, we cut greenhouse gas emissions due to hospital operations and energy use by over 30%. Well on the way to the 41% that we're going backwards on with respect to Canada's commitment right now. Over 30% getting there. But the ones at the top, we're not asking to do as much as the ones at the bottom. Like your fair share is get good. Don't get great. Top quartile is not great. There's a whole bunch of hospitals way above that top quartile. Many of those are in this room. But if everybody today makes the commitment, I'm going to understand what my fair share is, what I can say by getting there, which every greening healthcare member does now. You get an annual report telling you that. But if you're not a member of greening healthcare, send us your data or tell us the name of the hospital. We'll tell you your fair share. Make that commitment by 2030. I'm going to get there. And we'll come back to this in the redevelopment panel this afternoon. This is the same thing with new hospital performance. I'll build more on this after lunch, but the National Energy Code of Canada right now, the archetypal building hospital would be at the top there. These are all new hospitals from UK, California, New York, Alberta, BC, Ontario. None of them comes close to where it should be. We are doing a terrible job on energy efficiency and environmental performance of our billion-dollar investments in new hospitals. And if you can't get the brand new ones right, when will we ever figure out how to do the thousands of older hospitals? This is a big deal. We'll come back to this afternoon. Just for fun, we said if all those hospitals met the National Energy Code, how much would we save? And for that group of hospitals, it's like over $30 million a year, which over 30 years, we could build another hospital. It's $1 billion. Like financially, this is killing us. Like we can't afford to do this, but environmentally, it's killing us worse, and it's literally killing us. So again, we'll come back to this afternoon. We talked about your fair share energy targets. If you're a greening healthcare member, you've already got this checkerboard chart for yourself. You already know what your number is, and it's my friend Alan Kelly's. It was at one time with him, it was 1.1 million. Now it's $760,000. He's got that in his head. This tells you how much gas you can save, how much natural gas, how much electricity, how much greenhouse gas emissions. That's what this is all about. But you can have, for your hospital, this chart that tells you how much you can save. We can have a conversation about it. We can talk about, well, I got 2 MRIs and I got this and I got that. Those adjustments are easily made, but you got to start off by saying, where am I on the rankings? And if I was to get to a good point on the rankings, financially and environmentally, how much would I save? That information is readily available. You need it to set the stage for planning, to have the conversation with the executive, with the board, with everybody that will become part of this big collaboration to help save the day with respect to the climate crisis, with respect to, frankly, saving the world the way that we know it. I'll come back to that later today. So let me hand this over, if I may, to my colleague, Gillian. She's been spending time with a number of you and with other hospitals saying, I hope what you've seen so far says that financially, this makes perfect. There's no argument against this. There's a great return on investment. Like no hospital would not want the financial returns. So if it's that obvious, and if we know the world is in trouble, why aren't we doing it? And Gillian set out with, again, some funding from our friends at the IESO to ask the question, and about to share with us some of the answers.
Thanks, Ian. I'm a little shorter. Hi, everybody. So not surprising, and I really enjoyed the presentation from Dr. Anita Rao, because it's an example, a prime example of how you really get this organizational piece right. And when we talk about how to do that, and we talk about it's difficult, sometimes, and actually a lot of the time, the difficulty is the human element of getting your teams together, of getting people to work together, collaboration inside and out. And that's much trickier than, and frankly, for some of us who are the more technical, it's easier to, work away in the boiler rooms, and that's easier, right? That's not people. I can work on my spreadsheet. The people stuff is hard, and we always say that. So we've developed this kind of a simple, Ian calls it the roadmap to the stars, our sort of the building blocks of organizational alignment. So really, you have to get the pieces in place, and Dr. Anita was talking about, you get the executive support and to take time out of your day, because a number of people that I talk to, this is side of the desk stuff. It's not primary what we do every day. It's side of the desk stuff for a lot of people. So getting senior management support, getting the funding often for some of these, taking a risk, getting support from both clinicians, from the staff around, from nurses, everyone around you, all that's important. And putting things in place to make sure that your savings continue, because it's disheartening when you have a great project, you have great success, but that doesn't continue. You come back a year later and all the savings are eroded. And I think that's part of what Ian's showing in those charts, where you see hospitals not really moving or they're going in the wrong direction. That's a result of not having that organizational structure where you're measuring on an ongoing basis how you're doing. You're keeping track of how you're doing. You're reporting back and communicating with people around you so that those persist. And recognition is a big piece. I've heard from a few people as I spoke to them about how important it was to be recognized and their determination to be recognized as they go. And that building that capacity, having designated people take responsibility. Often we do hear, this isn't really my job, or, that's just a piece of my job. Nobody's really responsible. So you don't get the results. I think that's absolutely key. How you develop your service contracts is important. Your relationship with your service providers. I've heard from a number of people speaking to you individually about how important it is for a person. They got a great service contractor, so they achieved fabulous things. We like to think of those things that it's not just another company. It's actually a relationship you develop with that person. And it makes a difference if you get a good service contractor, or when you have a good relationship with, or one that, it's just transactional. So I think that's really important. And training staff, we often forget that when we list things, but getting staff trained up before we implement and after, and continuous training and kind of just-in-time training, really, really key, and not high on people's radars. So moving forward, what I have been doing, what I've been doing is talking individually with hospitals, particularly around the conservation demand management plans. So you've all put together your conservation demand management plans, and we've been speaking to individual hospitals around what's getting implemented, how are those coming, what kind of targets were set, what are your ambitions for the next 5 years? Because these plans are very critical. This is our pathway to 2030, essentially. When you've wrapped this up, it's basically 2030 will be on your doorstep, because they're done by 2029. So really, really key. What we found is, sorry, there's a little typo on the slide. It was supposed to be 2019. We found that for various reasons, particularly COVID, a lot of the 2019 plans never really came to fruition. But some people still persisted and got great savings. So some hospitals, despite COVID and all of the restrictions and all the difficulties, they persisted and got some great savings over this time. And we saw the winners in the slide previously. A lot of the upcoming plans are focused on modest savings. Now, I have heard from people that you like to aim low and achieve high, and that's fair, but there are a lot of sort of modest operational savings. A lot of these plans are really focused on modest operational savings. I'm hoping that particularly after day, you'll have bigger ambitions behind the scenes, that your plan will come in low and you'll overachieve by, by geometric measures for sure. There was little mention of decarbonization. So we've been at this for a while. We've been talking about decarbonization for a while, but these conservation demand management plans didn't really talk that much about decarbonization. Again, I hope that's because you're aiming low publicly and hoping to achieve high when you actually get there, but that's what we were finding. Lot of focus on lack of internal capacity. So I heard from lots of folks that don't really have the internal staff. So they're either going to do turnkey projects wholeheartedly with their service contractors. So I hope service contractors have got their ears open, because they're just not the staff inside hospitals to do this. It is side of the desk for a lot of people. So these kind of projects, that's what we're going to see from these kind of projects. And amazingly, a lot of hospitals have major redevelopments in the works, like they're planning them, they're 7-10 years out, but that's going to take focus away from your director of facilities, because they've often got to manage both of those things in some of the smaller hospitals. So that's part of that. The other thing I want to speak to is that I didn't hear a lot of engagement of clinicians, when green teams really hit a big roadblock with COVID. Because you couldn't meet, because people were really stressed, green teams fell off the wagon a little bit. So hopefully, with the great example that you've provided at Trillium, that people will revive their green teams, and hopefully they'll get some executive support. Because as you can see, that collective genius, that working together, is really going to make a difference in getting things done. So, not surprisingly, for those of us who've been here for a while, working at this for a while, internal project champions make all the difference. Having somebody who persists despite even when there isn't executive support, who persists in making savings with what they have, or who can push till there is internal support, that's everything. We know who our internal project champions. In fact, you're probably mostly in this room because you're here. They really make the difference. And they're the energy and the driving force behind all of the change that we see. Support from executive really helps as well. That's a big piece. I've talked to the limited capacity, but I can't emphasize that enough. And particularly as I spoke to hospitals further and further away from urban centers, it's really, really difficult to replace the staff they have. The staff are aging out and they don't have a replacement plan. So I think this capacity issue is going to be bigger and bigger. And so trusted service contractors are going to play a bigger and bigger role in what happens. I always think people are going to say, oh, there's no money for anything, but people were finding money to do operational changes, which is exciting to hear. So nobody really said, oh, I can't do anything. Oh, I can find the money. There's ways. I've got ways. So that's pretty exciting. People are taking action and they have funding. And I also think it'd be interesting to see how people are going to ensure these savings persist, put standardized measures, green standards into place, put preventive maintenance. I heard that a bit, only a couple times, but preventive maintenance so that we don't have these problems come up over and over again. So a lot of interesting things happening out there. I will hand this back to Ian. Happy to take questions after or during the break if you have any questions.